So I'm following up David's presentation, and we're focusing more on the NHI, although this whole train the trainer is about the health system in general. So I realize that we use the term NHI quite glibly, but I'm just going to ask you, so what does NHI stand for? What's the N? National, right? So what does it mean to have a national health system? What's the implication? Can the Western Cape decide that we don't want to have purchaser provider splits? So in other words, once there is agreement that this is a national system, you can't opt out. Everybody has to do it. It's the whole country, okay? Okay, health we've been discussing, which is not just health care. Okay, health is more than just health care, as David has shown. And what do we understand by insurance?
Taking money from your account.
Yeah. You take the money from your account, and where does it go? Somewhere? Somewhere?
You don't know where to the future, somewhere.
Future, yeah. So if I have a policy which is like a funeral policy, okay? I'm alive now, but at some point I'm going to die. My family will have costs. So I put that money away, and everyone's money is shared. Okay, so it's not used now, and it's also shared. So you can't use it right now, and you can't necessarily claim your amount back at this point. So if I insure, yeah, Catherine?
Yeah, the way I was looking at it, I was saying insurance is the assurance that you will have a better care
Yeah.
in the future.
Yeah. So a young person puts money into health insurance, but they don't use it because they're generally healthier. But the older person or someone who's sick will need that. So it's a big pool. So insurance is really a pooling of money. It doesn't necessarily mean there's a profit being made on it, unless sometimes Discovery actually is for profit. So if anyone's on Discovery medical aid, they make a fat profit out of it. But it doesn't have to be like that. So I used to work for a trade union that had a medical benefit fund. The workers paid in a portion of their salary. It went into a pool, and it paid for healthcare for all the workers. There was no profit. It was, the money was used to run the benefit fund and to run a clinic as part of the benefit fund. So insurance doesn't necessarily mean someone's taking a cut, but it can mean that if it's for-profit insurance. But it's basically a pooling. And we pool the money amongst people, and we pool it over time, so you use it later. So that's the basic concepts of NHI. So you've heard from David, the state. So let's just maybe talk to the person next to you. Think of 2 motivations for the NHI in South Africa. Just 2. Just spend a couple of minutes just talking to the person next to you.
Mm-hmm.
It's just very hard. I think these are whiteboard markers, eh? Yeah. I think it's just that thing is very old. Okay, we don't have to make a big thesis out of it, so let's just start at the back. Anybody want to suggest why we need an NHI? Or why there should be an NHI?
Anybody?
Annalie, just give it to anyone you... There we go.
Okay.
Bobby.
The reason that we need an NHI is because that we must be sure about our health.
Yeah.
We must be sure about our health, that the system is working accordingly the way we want it to work.
So,
To be
so
sure
it meets our needs,
about
meets
our
health,
needs, yeah.
our health needs.
Meets needs.
Okay. Yeah, I think Bobby had a no.
so that everybody can enjoy the benefit of dying later.
Longer living. But can I ask, what else can we enjoy the benefit of if we have a better health system? Okay, so, all right, so all those social determinants of health are improved. Okay, anyone else?
It's about redress actually as well. So it's about using the health system as a mechanism to build social solidarity and cross-subsidization to redress a lot of the history that Shanaz brought up earlier. The underlying principles of the bill are in fact that social solidarity and cross-subsidization, so that everybody gets to benefit.
Yeah. Okay, so really important, yeah? We want to record you. And it's going to be a hell of a fit at the end of this workshop.
Effective use of state's funding, in my idea.
Okay.
Yeah.
So we sort of say that it's efficient use of resources in the states.
Yeah.
Resources are our resources because we pay tax. Might pay income tax, but you pay VAT on bread, so everybody pays tax. So efficient use of resources. Okay.
Not the back. There's a game for me.
So that people can have same benefits.
Oh, you're going to have to talk a bit louder? No, the mic's not working. The mic's for the movie.
So that people can have same benefits.
Equality.
Have the same benefits.
Equality, okay. Okay?
Yeah.
Yeah?
I like it when they say efficient because I remember PFMA. You always say efficient, economic, and what is it? Economic and effective.
Okay.
Yeah.
All right, so I'll just put effective as well.
So I would add quality to that. But I think part of it is just the point of the NHI is also to ensure that everyone has access. And sorry, I had a point which is out of my head now.
You can get the mic back afterwards if you want.
I'll get the mic back after.
Yeah, thank you. You will improve health. People get access to better health care. But my worry here is one.
Yeah.
That we get quality health in private hospitals. So what if this NHI, maybe we all have this card, and we're going to run away from public hospitals which are deteriorating now, and all of us move into these private hospitals and making the shareholders of private hospitals more richer instead of getting no proper health care? Wow. I am not sure. Why don't we improve the existing public hospitals? I mean, I'm very skeptical.
So that's a very good point. We're going to come to that in detail. But what you're saying is there might be an impact on the public facilities, and that's a bad impact. So many people have suggested we should improve public sector facilities as a focus.
So my point was about the approach to health, and it's about the point of a health system that's geared towards the needs of the people and not for profit, and it's also around prevention rather than just focusing on responsive care.
Okay. Prevention plus care plus cure. And your first point was? Approach, okay. Okay, I think there was...
So I'm just going to add to perhaps the idea of redress and just add the word equity. So linking also to the approach of primary healthcare, but mostly around equity. Thanks.
Where did I put redress? Yeah. I'm running out of space here.
I'll wipe it now.
Are we covered? Okay, so look, we're going to pick up on many of these things and keep some of those points as we go forward. So maybe this idea of meeting health needs and approach that prioritizes people over profits is about health as a right. Okay, it's one of the fundamental principles of PHM. And surprisingly, it's actually what the Department of Health actually says it believes in. So this is the motivation from the department from, I think, 4 or 5 years ago. Talk about healthcare as a human right. The right should not depend on whether you're rich or poor or where you happen to live. So if you're in a rural area or an urban area. And it acknowledges large numbers of people continue to die prematurely and suffer unnecessarily from poor health. And we know we have a skewed healthcare system. And without the NHI, the department says, the burden of disease will not be reduced because the majority of the population who suffer the greatest ill health will not access good quality healthcare. Okay, so access to healthcare, we mentioned quality, we mentioned equity. Okay, so one rationale for the NHI is to think about health as a right, although we understand, as David pointed out, health is more than just health care. Okay, the second problem driving this is this slide, which many of you will have seen. So this is the amount of money, this is the share of income. And this is the population here. So what this is saying is 10% of South Africa's population are here, another 10% are there, another 10% are there. And they're organized from poorest to richest. So it's saying the poorest 10% have less than 0.5% of all the money in the country. Okay? If you add the next group, it's 1.2%. As you go along, they own more and more. So in fact, only 10% of the richest people in South Africa own more than half of the wealth in the country. Okay? So this is a slide showing you how unequal we are as a country, very unequal. We are officially the most unequal country in the world. We were competing with Brazil for many years, who were slightly ahead of us. And then they had a lot of social reforms, and their inequality coefficient went down. But Thomas Piketty assures us that we are now the worst in the world, although I think Brazil's turning around again. Yeah?
I think just a comment
would
be that when we look at the middle,
is
that the middle necessarily isn't that rich either.
Yeah.
I think we're just talking about a study that we read, that the middle's between 10 and 15,000 rand a month.
Yeah.
Yeah. So the comment is just like, the middle isn't that rich.
So it's not like we're going like that. It's not a straight line. It's actually like this.
Yes. It's like incremental increases in that.
So it's sort of really here. Yeah.
The middle are often one paycheck away from becoming the poor.
Okay. Very good point. Yeah. Okay. So the NHI recognizes this, and it's one of the problems that it's trying to solve. That because income is so unequal in South Africa, people who are surviving or managing are, as you say, one paycheck away from being poor. Or if you get ill, you get tipped into poverty. If you can't cope with a family member who has cancer, your whole household will become poor because you have to spend the money on healthcare, for instance. Okay, so this is how much is spent per capita in rands, so as a per person on average in the country, in the public sector. So this line is 2,000 rand, and on medical schemes, that line, that's about 6,000, and that's about 14,000. So what is happening there? From 1996, just after independence, to 2012. What's happening there? So what can we say here? If you're in a medical scheme, well, it's actually per capita. Whether it's better preference, we don't know. It's what's actually being spent. So they were spending, on average, more than 6,000 rand per person. The public sector was just under 2,000. So you agree that's about 3 times as much. So that's unequal spending. And what's it like here in 2012? Has it gotten better? Has it gotten worse? It's worse, okay? So that's about maybe 2,500. That's way up there at 14,000. Okay, so it's probably like 5 to 1. That was 3 to 1. Now it's 5 to 1. So this is what we mean by inequity. So you might say that there's more being spent per capita on people in the public sector, but actually in compared to the private sector, it's gotten worse. The gap has gotten bigger. So we're talking about that gap. So the NHI is responding to that gap, that there's unequal spending in the country, and we have limited resources for health. And if we're going to spend it so unequally, it's going to have bad implications for health in different ways. Yeah. Yeah. Yes. So it's a good point. So everyone hear that. So if you look at 1996, we were spending just under 2,000 Rand per capita. It's 2 years after the transition. It actually went down a little. Yeah, it actually went down. So what happened in this period? HIV. HIV started earlier. What happened in the economy? Gear, yes. So we had a fiscal constraint under gear. We shifted from the IDP to gear. So actually public spending was quite severely shrimped. And in the health department, actually spending went down per capita in that period. It's only just recovered and it's slowly increasing, but that's a good point. Okay. And in the meanwhile, expenditure on medical schemes has just skyrocketed. So, okay. So these are just a selection of different countries, and what this is,
Yes.
Yeah?
So you're saying expenditure on the medical schemes?
Yes.
By who?
It's per capita. So what gets spent in medical schemes on average per member. So of only about 16% of the population are covered, but of that 16%, on average, what's being spent per member is 14,000 Rand in 2012 per member. Okay. Okay, this is a picture of insurance as a percentage of all expenditure in different countries. So what this is saying, in Lebanon, 10% of expenditure is in the private sector. And look where we are. Okay? We have almost half of all our health expenditure is in the private sector. Even worse than the US. Okay, the US is a very capitalist private sector society, but not even in the US do they come close to us. They're about 35%. And the reason is because they have big public programs for war veterans, for the elderly, and for very poor. Although there are many problems with the US system, but even in the US, they don't achieve the levels of private sector coverage that we do. You can see Namibia is close to us because South Africa colonized Namibia, so they have inherited the kind of way we have done healthcare. So we have a very big private sector in this country, the highest in the world. And this is from the Health Systems Trust. They publish an annual district health barometer and a South African health review, so there's a lot of useful information. This is 2013-14, and they're comparing the expenditure per capita by health district. This is Alfred and Zoe, and the top is Namakwa. Okay, and this is the average. Which one's the average? This one's the average. So you can see in some districts it's around 500, some districts it's over 1,500. Okay, and there might be many reasons for that, but there's a lot of inequality across districts. Okay, so even in the public sector, we have a lot of inequality, and that has implications for the service. So how is healthcare financed in South Africa? So let's think about the population. You have 100% of the population. If you use different ways of assessing who's rich and who's not rich, well, about, let's say the top 16% would be considered richer households. Remember that the curve that went up like that? And the rest, 84%, are either very poor, or not rich anyway. And then you have private providers providing healthcare. You have public providers. And there you have private insurance. So that's Discovery and other medical schemes. People who are rich pay money into those funds and purchase services, get services from a GP or a private hospital or whatever the case may be. And about 44% of all health sector funding goes through that route. So just under half. Okay? Remember that 16% of the population are members, and what's being spent through that route is about 44%. Of course, we also pay tax. So government tax is used to pay for public providers. And that is about the same amount of money, 43%. So what's being spent in the private sector is about the same as what's being spent in the public sector, but it has to cover the 84% of the population. And in fact, some of the richer households will also contribute to tax through their income tax or other forms. But this 84% don't have access to private providers in that way. If they do, they have to pay out of pocket. Okay, and that's the balance. The 43 and the 44 and the 13 add up to 100. So there are some people in this pool who are having to purchase services, go to a GP, go to a pharmacy, and pay out of pocket, as we say. So that's how healthcare is financed in South Africa. Yeah.
So, just a question on how it's financed. So, from looking at that, would you say in that case that how we look to finance any government, financed, project in South Africa takes a model of a more communist way of going forward, or is it financed in a communist way? So in my understanding of communism and how the system works is that you give what you are able to give, and you take what is needed. So your need, you give what you're able to give. So the richer you are, the more you give. The poorer you are, the less you give.
Okay.
And you take according to your need. So if you need more healthcare, you get more healthcare. Depending on how.
Yeah. So I think it was Karl Marx's phrase, actually.
Yeah.
So the principle is you're basically contributing to a public system, and you're drawing from that public system what you need. So you can call it communist or Marxist or socialist or whatever, but that's the underlying idea of solidarity. So you might be wealthier and not use the system, or you might be healthier and not use the system. You draw on it when you need it. So a publicly financed system would not link it to the amount of money you put in. Okay? A private system links it to what you contribute to the medical aid. If you've used up your benefits, that's tough. If you need kidney dialysis and you don't have any more benefits, you don't get it. And if you don't get dialysis, you die. Okay? So that is the consequence of the private system. Okay, is that clear? Any questions on this? David? Yeah?
Well, it's not a question so much, but is it the case that those 16% pay everything that covers their health care, or is some of it subsidized?
Okay. So when people on medical schemes contribute to a medical scheme, they can also at the end of the year apply to the government for a tax rebate. So essentially they get less they get taxed less because they've contributed to this private medical scheme. So in a way, what's happening is that the state then is losing that tax money, saying to people, okay, well, good, you've contributed to that medical scheme, you're getting your care there, you're not coming to clog up the public hospitals, we're going to give you a rebate to encourage you to do that. And that's how the South African system worked for a long time. So basically that is lost money. That's a subsidy. So effectively the state is subsidizing that 16%. And the second issue is that in that 16% are a large number of public servants. So people who work for government, who are on private medical schemes. And there, the government's actually paying their medical scheme as the employer. Okay? You have an employer, usually it's the person shares half with the employer, and the state in that case is the employer. So the state is actually directly paying private providers to treat their employees. So there are two ways in which there is a subsidy of the private sector. And there's a lot of talk about how the NHI is going to undo that. And that's an issue, yeah? It's an issue particularly for workers who are on medical schemes, which I raised to PSI, that trade unions need to grapple with that. Because often workers in unions have fought for those benefits. And now actually they might have to think about sharing their benefits with a wider pool. Yeah? There was a behind David. Yeah. Behind you.
Me.
Yeah.
Okay, I'm going to play a little bit of devil's advocate
Oh,
because
sure.
these are some of the statements I've heard from my colleagues. So why should I, as the richer household who has enough money to buy whatever healthcare I have, now retract my benefits of choice and put my money in the government's pot of insurance? Shouldn't I have the freedom to use my money how I like because I already pay taxes?
Okay, well, how does anybody want to respond to that? Are you wanting to respond to that? Okay.
Yeah, thank you for that. I think the way you explain the 44%, the subsidy, people don't understand. Most of the people who are employed and our own benefits, this medical aids, are those working in government. So I don't know, is there anybody who's working in government who is rich? So that's the first question.
Yeah.
Now, the issue is, they say you pay R1, then your employer, which is the government, pays R2 for you in private. So I don't know if any individual is paying money there, because it's the same government which is paying. So I'm just maybe elaborating on what you are saying.
Yeah.
And then the very same people who say they are rich, they've been paid for in private medical, they come with tax rebates. So I don't know if somebody says maybe he's putting his or her money there. And anyway, there are very few of them.
Yeah.
You know, like the NHI says, we don't mind. But if you want to go to private, it's fine, use your own money. Then we'll talk about it.
Yeah.
The private will still exist. The public-private partnership will still be there. So people think that they are going to be destroyed. That's not the case. So I just wanted to clarify that.
Okay, thanks for that. So firstly, you're right. It's richer, not rich. So I think you're absolutely true. There are people employed by government who wouldn't by any standards be considered rich. But because they are wealthier than other groups and they are able to access private medical insurance. And the point you make is that at the moment what's happening is that people on medical schemes are actually getting a cheaper deal because of all the subsidy. So if they were to pay the real costs of their private health care, they'd be paying 3, 4, 5 times what they're currently paying now because of the subsidy. And there's nothing in the NHI which says you can't pay private providers, but you have to belong to the national health insurance because that's the principle of risk pooling, of solidarity. So everybody's in there. You want to purchase extra, that's your business. But you will know that if you take away that subsidy, it's going to be so expensive, it's not going to be worth it. Okay, and the point is, if the national health insurance delivers good quality care, even the rich will say this is a better deal. Okay, there are many examples around the world. So in the UK, there's something called the National Health Service. It's not an insurance, it's paid out of tax money. But successive conservative governments have tried to dismantle the national health insurance, but the public in the UK defend it. Even if they are conservative, they want to leave Europe, they voted for Brexit, they will defend the NHS because it actually brings them real benefits. It's a good quality service. So there's a lot to be said about social solidarity. David?
So when we say government tax, it actually means our tax, right? Every one of us. And if you look at the proportion of tax that poor people pay, even those who are below the lowest tax bracket, but pay on VAT, proportionately it's actually higher than what rich people pay. So it's completely false for rich people to say, we're paying all the tax, why should others benefit? Because actually everyone's paying tax. And secondly, and we'll get to it later, there's another way in which we, the taxpayers, subsidize the private sector, not just the tax rebates, but very importantly, in the training of health workers. Because the cost of training a doctor, a nurse, and other health workers is much, much higher than the fees paid. So, a medical specialist who might have had altogether, say, 15 years of training, actually has cost the state, i.e. the taxpayer, a lot of money. And that then goes to the private sector, which hasn't shouldered any of the training costs.
Okay, thanks, David. Very good point. Kafsa? Yeah.
Thank you. Just just to add on to what was previously said, and the motivation for especially our citizens who contribute to medical aid schemes. What I've noticed at our public healthcare facilities, so people work and they are earning enough to pay to a medical aid scheme and access better quality healthcare service. And once they retire, they are no longer able to afford that, and then they come to your public healthcare facility. So what you are doing while you're working and contributing to an NHI is actually ensuring that the time comes when you need to access the public healthcare facility, that you do get not a drop in quality service, but that at least by the time you get there, things are more level. Yep. So NHI would be leveling the playing field, so to speak, and making sure that everybody gets quality healthcare service. And for people, just to motivate them to make sure that they contribute or want to contribute, that is the reasoning also why it's important.
Yeah. Leanne?
Actually, I was responding to my colleague from Stellenbosch. She was playing devil's advocate. And I guess in the same way that, what did I want to say now? It was so clear before I started listening to everybody else. In the same way that we've spoken about how being healthy isn't only about what we get from the healthcare system. The healthcare system's only role is not to deliver healthcare, right? So the role of a health system in society is actually not only to deliver healthcare, it's also to deliver a range of other social benefits. And so we've spoken about the huge inequities in how healthcare is currently financed now, and we know how inequality continues to have its huge footprint on our society, right? So I guess my response often when that question is posed by people who don't want to give up their free choice is one about pointing out how currently actually they are benefiting unfairly from a system, and in fact, as others have raised, are already receiving a cross-subsidized healthcare system, but also that the function of the healthcare system is not only about delivering healthcare, actually it's about addressing larger issues of inequality in society. So the argument is that the healthcare system can be a leverage point to address wider inequality in our society, and that's something to work towards.
So I think it's a very important discussion, and it's something we want to try and pick up just while the mic's going to Sinisipho. The idea of frequently asked questions, what people are going to ask you or what people are going to counter, how you're going to respond to them. This is a good way of trying to establish these questions. So just keep them in mind for tomorrow. Or write them down.
Leslie, I think what I wanted to mention earlier, I wanted to mention that I think there's some arrows actually missing from that diagram, and I think that's what everyone is pointing out, that there should be an arrow going from government tax back to that 16% in terms of the subsidization.
Yes.
And
yes.
So I think we need to make that that diagram a little bit more comprehensive in terms of getting the right arrows, because that's the points that are coming up.
That's a nice idea.
Particularly at the moment. And then it's a more clearer picture that doesn't depict the private funding everybody, but actually that the government tax is actually going back into the richer 16% and back into also that the private insurance.
I'll try and think of a way to add an arrow that doesn't
Just-
confuse people. Okay.
In very subtle
Okay.
ways. But also, I don't have an answer for our colleague in Stellenbosch, but I think just a simple way, and I could just be wrong in the simplicity, but it's just to think about the money as a pool. And if you think about how money cycles from government tax to paying those who are working, and then back to government tax, and how that government tax is actually supposed to it's supposed to look after the entire population, and so and it's supposed to look after the entire population in a very fair way, you know. And what we are experiencing at the moment is inequality. You're getting 84% of the population getting less resources allocated to them, and 16% getting more resources allocated to them. But if you think of the money that belongs to South Africa as money that is supposed to serve the entire population, then the idea of the NHI is very favorable, and redressing those inequalities. It actually advocates for redressing those inequalities. And then the other point I had is why, I don't know, why are we calling it, I do understand why it's called a national health insurance, but I think the word around insurance is the actual problem, because I know that there's a lot of contention around the financing of the system, and actually arguments have been centered around the financing of the system. But because it's supposed to be a national health plan, it's supposed to be a national health service, and would changing that word insurance actually bring about a broader debate, on actually looking at healthcare and the health system as a whole, instead of just looking at the financing part of it. I don't know. I know that the contention, actually the battles, the debates and the battles that we're having, particularly at the moment between private and public, is actually on the financing, which is captured in the word insurance. But actually the national health insurance is not just about financing health. It's actually about a plan for a better and a healthier South Africa. But that's just to throw it out there.
So you're absolutely right. And a lot of people are saying what you're saying. And in a way, insurance it triggers not just the questions of financing, it also triggers this idea that it's private money, so I should be entitled to the benefit of private money when it's not private money. So it does feed that individualism. Okay, any other comments? Can we, Shanaz?
Well, just...
hang on, Shanaz is on.
I'm not sure if the point was made before, but I'll just say it again. It's just also that medical aids are not very good, actually. I mean, your money runs out so quickly. Most people actually go to private doctors, or and when you look at the burden of disease, it's not like you need your money for a once-off thing and you're fine. You probably need to claim regularly. Then people have multi-morbidities. So it's not very useful, actually. And then once you're done, you have to go back to the public sector anyways. So it's quite complicated. But I think the other point I was thinking about, Sinisipo talking about this graph, and I know it shouldn't go into this particular one, but I think when you think of the government tax and the flow, it doesn't go to public providers. It actually goes to provincial health systems, am I right? And then that's another very complicated discussion around which provinces get more money or less money, and then the efficiencies around there.
And of course, there are provinces and municipalities and
Yes,
other kinds of very complicated systems. So this is a real simplification.
Yeah, so I think maybe we need another graph showing how Treasury allocates resources and what is the inequities that are coming up there. And just to go back to your why NHI, I was supposed to say inequality, not equity. Sorry.
Okay. David, did you want to make a last comment?
Just a very last comment. People have said a few times that the private sector provides better quality care. And I think that can be contested. So certainly at for complicated conditions, the public sector is much better. If I were really ill and needed intensive care, I would try and get into the public sector, not the private sector, because in the private sector you don't have junior staff who are there on the spot and so on and so forth. And also, the private sector hugely over-services. So, for example, the caesarean section rate across the public sector in South Africa is just under 20%, which is in line with the international norm. In the private sector, it's about 70%. So there is a lot of over-servicing that is done, not necessarily for health conditions, but for the convenience of the practitioner or for other associated services to get their cut, like the lab services and so on. So I think it's really very important to understand that private sector is not always better quality. And I think what we're aiming for and what the minister keeps going on about, although we're a long way from there, is quality in the public sector.
Yeah. So if you just go back to that, this slide, you can see the expenditure has gone up. So clearly what people are being charged must have gone up because the membership of medical schemes has not changed over this period. It's still about the same as it was. And because it's costing people more in the private sector, there's a crisis. It's unsustainable in the private sector. So that's why, in fact, the private sector, in a sense, is almost welcoming the NHI because it could present an opportunity to save them. Okay, because this can't go on. Members won't accept this in the medical scheme. So that's exactly what you're saying about inefficiency in the medical schemes. Okay, so where are we now? All right, so how will the NHI change this? So if that is the situation now, NHI is saying, in fact, we are going to create an NHI fund, which is going to start pooling the money. It's going to be free at the... it's free for all and there's no co-payment. And basically you have providers, whether they're public or private. Okay? And in the interim phase, you can still get private insurance as a top-up, but that will be outside of the system. But everyone must pay into the NHI fund. Okay? And then over time, the idea is this fund will grow and eventually wipe out private insurance. Because basically, if you can get good quality care through the NHI, why are you going to pay extra to go to private healthcare? So that's the vision. Okay? And partly where the money will come from will be to undo that arrow going back from tax to as a subsidy to rich people. And so, but there's a lot of discussion about where the money is going to come from to fund the NHI. Oops, sorry. Okay. So when do you think the NHI was first discussed? Sorry, question. Yeah. Yeah.
Just a question that does the public sector now want to take over private, or do we want to actually contract private? So when we say that the NHI fund is supposed to be taking over private sector, are we contracting private sector, or are we actually taking over?
Okay. So the only thing an NHI fund does is to purchase the services. The services can be provided by the public sector or by the private sector. So it's not taking over the private sector providers. And it's not taking over the private insurance because it's not meant to be private. They will exist if they can make a business out of it. It's simply because the NHI fund will pool so much of the funds, it'll be able to compel the providers to charge less. The moment the specialists can charge more or less what they like. But if the NHI fund has a lot of money and it concentrates that money, it can bargain that down. We've seen that with drug prices. So the private insurers will actually, their business basis will fall away. So it's not stopping them, but it's sort of crowding them out, if you see what I mean. But the providers can be private or public. Yes.
Depending on
yes.
what the people that are leading, the people that are making decisions with the NHI fund, who they want to contract because they can contract more private.
Sorry, so this is going back to the impact on public facilities? Can we get the quality up so that people actually choose private? More people choose public better than private, or will whoever is sitting at a decision-making level regarding the NHI fund, will we just contract private and we just make the private sector much bigger, funded by the NHI fund, and actually not concentrate on making our public health system actually much stronger to actually attract people to go more public facilities than actual private facilities? I don't know if you get.
I get
so
it completely.
even if it actually, even if the NHI takes over, but who is it really benefiting? Will it benefit more private by getting them in on the fund, or will we actually lean more to trying to get our public facilities at the level that they're supposed to be, so that people actually go to them more?
Okay, that's an excellent point. We are going to come to it later, because basically the NHI bill talks about units for contracting at primary care level. So somebody's going to have to make a decision. Should I buy in a service from a private provider, a GP, or should I invest the money with the local district hospital? And that level of detail is not provided, and it's very unclear whether those contracting units will have the skills to actually invest in the public sector. They'll just say, oh, here's a good pitch from Medicare or Discovery, let's go with them. And so you're right, public sector facilities won't improve if resources are not allocated there. But that's the implementation side. But it's a good point.
So I just have a question. So where are, and maybe it was implicated and I didn't get it, so where are firms in that previous model or in the current model? Because is the NHI intending to bring firms into the process, or what,
This is just financing. So they're going to pay in. If you have an employee, you will pay not to a private medical scheme, you'll pay to the NHI.
Okay.
So that money you would have paid to a private scheme, you will have to pay to an NHI. Catherine?
Yeah, and with my understanding, that time minister was at Wits.
Yeah.
He spoke, when he was speaking about this NHI, he spoke about the public hospitals are crowded.
Yeah.
So what they are going to do, they are going to try and elevate that crowding by taking critical patients to the private, and the government will pay for those, but they will be negotiating to say, like for circumcision, if they say it is 4,000 for NHI, they will be paying 2,000 as a government or 1,000 as a government, because in government it's free, but because in public but because of the agency, then it's how they are going to deal with it. Even if any operation that they need to be done to a patient which is agent and they cannot do it in the public hospital, then they will negotiate to say, let your rates down and then we will pay for this.
So that is what the minister says, and that's what is the argument. But it's a big question about whether the health department will be able to negotiate those rates. And also the private sector will want to use up or offer services which are profitable. So they won't offer services that the Department of Health might need most. They'll say, no, we can offer this. Sometimes it might be what the Department of Health needs, but essentially the private sector will try and maximize its profit. It has hospitals which are actually with services that are empty. Basically, they have very low bed occupancy for certain services. And for them, it would be a benefit actually to offer service to government and charge, but the real question is about how much are they going to charge. And they might charge so much, it's actually not worth it. You might as well employ a whole oncology service, for instance, to deliver services in the public sector. So those are all questions of implementation. Yeah. Okay, can we move on then? Okay, so NHI is a current hot topic, but when do you think it was first discussed in South Africa? Anybody?
Wasn't it discussed post-apartheid era?
Yeah, it was.
And then again, it
Okay.
became a hot topic in 2002 around.
Okay. Any other guesses?
I think I read somewhere that. I think that I read somewhere that it was discussed in the 60s already. Something
60s?
like that.
Okay. Okay. Hand at the back.
I can get
Afternoon. I guess it was first discussed in late 1940s after Emily and Sidney Clark.
Okay. So Emily and Sidney Clark. Anybody heard of Emily and Sidney Clark? Okay. In fact, there was a committee of inquiry on national health insurance in 1935. So it was actually under the Smuts government where they were thinking about it. They weren't necessarily doing it. The National Health Services Commission is Sidney and Emily Clark's era. So they created something called community-oriented primary care, which actually is the forerunner of primary health care, the Alma Ata Declaration, and our current ward-based outreach team philosophy, where you have a facility in a community, and that facility serves that community through community health workers and integrated services. It is true that after independence, we had a commission of inquiry into the national health insurance, but it actually has a much longer history. South Africa was very influential globally in driving primary health care, the ideas. And of course, it's gone over various stages since then. This is a bit of a map of the last few years. So 2007 was the kind of decision made by the ANC Policy Conference. We will have an NHI, okay? And that decision still stands. So there was a task team, an advisory committee, a green paper in 2011, which some of you might have commented on, PHM did, then a white paper in 2015, then a white paper, white policy paper, and implementation structures 2017, and then last year the bill. So that's the trajectory, and the bill is still there, and we're told it's going to come up before Cabinet and Parliament soon, but anyone's guess about what's going on there. Okay, so what's the intention of the NHI? It wants to provide universal coverage in the form of financial protection and access to needed care. And originally it said all legal residents, so it raised the question about migrants. Okay? So financial protection means if you get sick or you need health care, you don't go into poverty as a result. You are protected. It's like the insurance. Also talks about addressing the inequities of the past, so that's points people have raised. Ensure there's a unified national health system that accords our citizens sufficient financial risk protection from catastrophic health-related expenditures and improves the health outcomes of the population. And just to repeat the PHM mantra, if you want to improve the health outcomes of the population, health care is only one piece of the puzzle. Okay, because as you've seen with HIV, child health, diarrhea, all those other things outside of healthcare services are needed. Addresses challenges in both the public and private sectors. Okay, in other words, it's saying the health system must be integrated, one whole. How will it do this? Okay, how's it going to improve the performance of the public sector? Okay, 3 things. We have national core standards, we have the ideal clinic, and we have primary healthcare re-engineering. Has anybody heard of the national core standards? Okay, they are? Anybody? What is the national core standards? So we have something called the Office of Health Standards Compliance. Sounds very draconian. And they go around and they inspect facilities, and they use what are called national core standards to inspect the facilities. And if the facilities aren't up to scratch, the facility has to have an improvement plan and say, okay, we're going to do this and this and this to meet the standard. And then they get inspected the next time, and they see how well they've done. Yeah. So do you think, so that's happened. They've had like 2 or 3 rounds in South Africa. And do you think it's had any impact? Not really, you're right. So in fact, some facilities have gotten worse. Some have gotten better. But actually, if you had to plot them on a bar, it's gone up just a little bit on average. So it's not clear that the national it's working, although it is early days. Catherine?
And you know, when these national core standards are coming to my clinic, like for my clinic,
Yeah.
if I'm short of some equipment, I had to borrow from the next clinic because they don't purchase everything for the clinic. But I had to borrow from the next clinic.
So you helped
then
cheat.
What happened?
You helped cheat on for your clinic.
So what happened after that? Because I must take back those things to the clinic, which means I'm not ready.
Yeah. Okay, so any inspection enforcement will depend upon, compliance, and people game the system, okay? But even when they game the system, things didn't improve all that much. Okay, the ideal clinic. So originally, national core standards was hospitals and bigger facilities, and the ideal clinic was just for clinics. They're quite similar, but it's also an audit tool for clinics to match themselves to a standard. Primary healthcare reengineering is this idea that we're going to strengthen primary healthcare through ward-based outreach teams, and there is a slide later. Okay, we're going to draw in human resources that are in the private sector, so that is we're going to contract with GPs or contract with the private sector if we need intensive patients transferred to intensive care beds or things like that. We can have a contract with the private sector to provide that. Or if there aren't doctors or certain kinds of health professionals needed for certain care, we can contract them to provide it under the NHI. Okay? Oops, sorry. Then there's no opt-out. Okay, meaning that everyone who's in South Africa contributes to the NHI. So you might want to say that I have my own money and I want to contribute, but that's tough. Okay, the NHI won't work if people can start opting out because it has to be for everyone. The benefits entitlement is for all. So you don't get the benefits according to what you pay. You get benefits that are agreed by the fund, and it will do away with that tax subsidy. Okay, this is primary healthcare reengineering, the model. So you have a district management team. So for Cape Town Metro, for instance, is a district. There'll be a district management team, and they'll have specialist support teams in different areas. And for instance, with child health, there's an intent to promote, get policies in place that would improve child survival, reduce child mortality. The district hospital, the community health center, and the primary care facilities would be supported by this outreach team, which has a nurse, 2 nurses, a community health worker serving a defined area. There'd be also school-based, where's the school health services? So the idea is there's a package of services which tries to locate health care delivery in a promotive and curative way, preventive, curative way in the communities. Primary healthcare reengineering. So that's one of the platforms for the NHI. And as we know, these ward-based outreach teams have had a very checkered history. So many of them aren't functioning properly, and the district specialist support teams, many posts are not filled. This was an idea I think the minister brought back from Brazil after he went on a visit to Brazil, where they've had a very successful family health service which put in place this model, but they invested a lot of resources in it. They improved health outcomes fantastically. This version is like a cheaper version of what the Brazilians did, and we're not even finding enough resources to implement it. Okay, so what will the NHI be based on? It's going to be based on these concepts: universal access, mandatory prepayment, comprehensive services, financial risk protection, a single fund, strategic purchase, a single payer, and it'll have those principles. So I'm going to try to do something now to ask you to discuss in pairs different things, okay? You two are number 1. You two are number 2. Number 3. Number 4. Number 5. Noe, you number 6 with Violetta. Number 6. Number 7. Number 8. You two. Number 9. Yeah. Number 10. Number 11. Tinashe, you'll have to find somebody for 12.
Yeah.
Did I miss you?
Yes.
Oh. Tinashe and Cleo, 12, and two of you 13. And we'll catch up effectiveness afterwards. Okay. So just buzz for a few minutes. What do you understand by those terms? Okay. Just simply, what do you understand by those terms? Some of you have got like really simple things, and some of you have got quite complicated things. Okay, this is just meant to be a quick discussion. Okay, where did we start with universal access? Right here. So what do you understand by universal access?
There you go. Yeah. Our understanding with the universal access, it says to us no boundaries, no limitation.
Okay.
You can go to the nearest hospital where you are hurt. You are not going to say, no, I must wait and go to the public. If I'm hurt near the private hospital, I can get into that private hospital and get access assistance. No additional funds for special, let's say my funds are being exhausted. It won't limit me to say your funds are being exhausted, irrespective of who you are, unemployed or unemployed, and then limits of number of times needed for your treatment.
Are you suggesting that?
Yes.
Okay.
That's what we are suggesting.
No limits. Right?
No limits.
She means
No limits. Okay. So that's what medical schemes do. They basically cap your benefits.
Now your money will be.
But a universal access means there's no cap. So it's for everyone, and whatever care you need, you can get. And you also spoke about geographical access.
Yes.
Yeah.
Not
So if the NHI said you can only go to the facility, whether it's public or private, in your area, would that be universal access?
No, it would not, because because it should be my choice.
Yeah. So in fact, the NHI policy paper, the bill isn't clear, was a little bit unclear about this because it said the benefits should be portable. You can go anywhere. But at the same time, they said you'll be encouraged to use the facility nearby, and if you go somewhere else, you'll be financially penalized. So there was some contradiction there. But our understanding of universal access is basically everyone would have access. There shouldn't be a cap, and if you need care, you get it. Okay, and there shouldn't be obstacles to getting care. Okay. All right, who did mandatory prepayment? Okay.
Okay, so our understanding of mandatory prepayment was the first thing that it's inclusive, everybody pays.
Yeah.
But even though everybody pays, we all pay according to a scale. So it's proportional according to how much you receive is how much you're going to pay. And that in itself should form a sense of unity, that we're all taking responsibility. So it's a shared responsibility of the NHI, as well as thing that has already been highlighted, that the benefits are not linked to payments. Even though, let's say I earn more and I'm paying 40% of my tax, it doesn't mean I'm entitled to a specialist unit in a special area.
Yeah, 40% of the benefits, yeah.
Or 40% of the benefits, yes.
Okay.
Yeah,
all right.
that's what I understand.
What if you can't pay anything?
You still have access.
Yeah? So what does mandatory prepayment mean there, in that context?
Wouldn't you be covered then by the fund because you're in a certain group?
So the state will pay for people who can't afford to pay anything. Okay, so basically if you're unemployed, there'll be mandatory prepayment, but it won't be you paying out of your pocket. It'll be the state paying for you because it'll say there's a certain proportion of people who can't pay anything. Or the state will pay for it out of the VAT you pay on the bread you buy, for instance. So. Okay.
And one thing also that I just thought of now was that there'd need to be a level of like fair disclosure of how much you actually earn, because I know at the at government hospitals now there is like a scale almost that if you're in a certain bracket you pay a certain amount, but I'm not sure how that is actually used. People lie, or I'm not sure.
I'm sure people do under-disclose their income in order to avoid payments. Yeah.
Especially big corporations.
Yeah. So tax avoidance is a big issue as well. Okay, who did number 3? Okay. Yeah. Okay, you did number comprehensive. What do you understand by comprehensive?
Yes, so we had a discussion around it, but comprehensive services, we're talking about all services must be available, and we're talking about it should be available at all levels of health, even bringing it down to primary health care. Okay. So if you're making like a one-stop shop, we're hoping that the NHI will also cover that.
Yeah, you said that it should be available, there should be comprehensive services at
primary, intermediary, and tertiary service level, and it shouldn't be limited to what is currently available in the public sector, but it should be expanded to auxiliary services like therapists, dental, and other services.
So there are services we consider as like personal services, curative services, and then there are things like health promotion. So would you consider that as being the spectrum of comprehensive services?
Maybe not immediately, but it should be a phased-in approach to expand the services.
And at the moment, not every service is available at a clinic. You have to go to a community health center for some things, and then to a district hospital for some things, and then a regional hospital for some things. Does that fit with the idea of comprehensive services? I think it's reasonable to have care delivered in that way. If you need something more specialized, you go to a higher level.
I think it is reasonable.
So long as the primary level can refer you and there's no obstacle to getting there, so which often happens. Okay. All right. Number 4, financial risk protection.
Yes, we see that one, that the government will be paying for all our services, health services. But somehow, South Africa, we've got this high culture of corruption.
Yeah.
And I do feel that maybe the private sector will offer certain services that are not available in public sector.
Yeah.
And then if you are a sick person, you need that service, you have to go to that particular hospital. And maybe that particular hospital can double the price. You don't know this culture of corruption. While that, you may not feel that as an individual, but from that pool of money, I mean, maybe you know what happened with the PIC. I mean, our monies may not be protected, but as an individual, you can be protected.
Yeah.
You won't be paying much prices. And then that fund of the NHI will pay for you. But I think we are at risk of monopolizing certain services. So, the private sector can be good maybe in treating diarrhea, and if you've got a diarrhea, I can't go to Guguletu Community Health Center. I must go to Vincent Pallotti, and Vincent Pallotti will be making a lot of money because it is treating a lot of people with diarrhea, and we can't get these experts in other hospitals. That's my fear.
Yeah.
But as an individual, I can be protected. But, I don't know how will that last us because of the corruption as a South Africa. Yeah.
Okay, so that's a very important point. So financial risk protection is about protecting the individual. And basically, once you're in the fund, you should be protected. But what you're saying is how the money channels through the system could actually be corrupt. So if a private entity maintains the price of something very high, so a lot of people with TB, and some people have drug-resistant TB. Cost of drugs for drug-resistant TB are very expensive. And they're expensive because of patents, because the companies are not reducing the price or not allowing competition. So you would be protected because you'll get the treatment, but the fund might say, well, we're going to go bankrupt because we're paying so many patients, drug-resistant TB medicines. So that's a different issue, but it's related. So thank you. Okay, single fund?
So the way we understood the single fund is basically the pooling of financial resources into a single fund that comes from a tax base and from where health services are then purchased. We highlighted a couple of issues around that have been spoken about. Obviously, as my colleague mentioned, the issue of corruption and who has oversight of that fund, and that Treasury or at least Department of Health, or it's not really clear who has oversight and what representation there is from, for example, civil society in controlling the fund. And yes, so just the importance of the single fund as a mechanism for enabling equality by, pooling wealth, distributing it.
Okay, so we can't have a national system if there isn't a pool of money. Yeah. If different people control different pools of money, so that's really important. But you do make the point that, and what's not clear in the bill is the extent to which corruption will be controlled or prevented in the way it's governed. So the governance of that fund is really important. Okay. Who had a strategic purchaser? Anybody who had number 8?
Number 8?
Number 6, sorry.
6.
Number 6.
So it should have been there, but I think we both groups, G7, single payer and
All right. Shanaz, you've opened your mouth, now you've got to...
Okay, so we didn't actually discuss strategic purchaser, but I'm going to just give a guess because I should know this. I just don't. Can't think of it right now. Okay, so I think it's about deciding how you'd use the money and what would be part of that comprehensive package of services.
Yeah.
And the fact that it's about who's purchasing, right? Okay, fine. I'm sorry. I'm not thought about this at all on Saturday. So many excuses. But actually, isn't it also around if the hospital is meant to provide services, they are the purchaser of services out of this NHI fund. Okay, and then it's around what services they would be available from the fund. So maybe the hospital will have a package of care for critical conditions, but not for specialized conditions. I think I'm just going to pass on this one and pass it over to Leanne. She knows more.
So actually, for some bizarre reason, I was reading about strategic purchasing this morning, even though it's Saturday. And I read a really helpful thing because I've been struggling to understand it myself, actually. We have a mutual friend who's all about strategic purchasing. If only he was here. Yeah. But what I was reading was strategic purchasing and passive purchasing, which is the opposite of it. And that for me, made it quite a lot clearer. So passive purchasing, the two kind of extreme examples they give are one where a province is given a budget and they're with a cap, and the province then spends within that budget, and that's how they're guided as to what services they can purchase. And the other extreme is that a bill is given, not this bill, but like the amount paid, and that you then pay whatever it costs. So in some ways, that's kind of how our provincial systems are managed now, and, aside from equitable risk formulas and complicated ways of national allocating funds. But when province gets a budget, they're given a budget, technically speaking, and they spend within that. Whereas in our private sector, often a bill is given and you pay whatever it costs. That would be called passive purchasing. Strategic purchasing is when you make much more strategic choices about a package of care and how you distribute that. So there's lots of different ways of looking at it, but I guess the main thing is that purchasing and procurement are not the same thing, actually. And it's about bringing in all different forms of intelligence, including the intelligence that comes from public participation in decision-making that influences what we buy with the collective fund that we have. So strategic purchasing should be about that.
So in other words, it's at a much higher level, and it's about deciding on which priorities or how much you should spend on which priorities, because often we do it passively, as you say, because it's been inherited from the last year's budget. Okay, so the idea of this would require quite a high level of understanding of the health system and where the health system is going to go. Okay, so is the sugar tax actually going to affect our non-communicable disease burden for the better, for instance, and planning ahead? And single payer? Did you discuss single payer?
Okay, so then we didn't go quite deep. We just made an assumption that single payer is the fact that the single fund is the only source of, that will be paying out for services. So the claim that will be made will come out of this single payer.
Yeah.
But just to go to strategic purchasing, because I clearly don't understand it very well. If the, I think what I don't understand is how exactly, who is the strategic purchaser, right? So you mentioned province, and then what about the private sector? Do they get to purchase? Does the province get to purchase? And you mentioned there's like, you've got to choose the package of services that, so government will decide what package of service they will be offering, and then who decides the cost of the services? So I think I'm confused around like, how does strategic purchasing operate fully? And I mean, just to go back to like, we went to this health system global conference, and there were so many sessions on strategic purchasing which I avoided. But it's such a big topic, and it seems like there's a lot of private sector interest in running these sessions at these big conferences, and it just, like, what does this mean for us in terms of political economy, and in terms of how do we in a civil society or people interested in equity, why should we be interested in strategic purchasing? Yeah, that's my
So the
question.
purchaser is the fund. It's not government or the private sector. The fund is purchasing. The Department of Health creates this fund, and one of the mechanisms through which this will happen is through the benefits that are agreed for, that will be paid for by the fund. The decisions that the fund makes in terms of the health system are strategic for the future of the health system. So it has to be influenced by sort of what the public wants, what the health department wants, but the fund is the purchaser, and it will purchase from the providers, who are the private sector. The fact that the private sector is really interested in this is because they know a lot of money is at stake there. So if there's a decision made to purchase the kinds of services that the private sector want to provide, well, that's good for the private sector. Or if it makes strategic decisions which are about strengthening the public sector or other kinds of services, it's not good for them. So that's clearly why there's a lot of interest from the private sector. Just to say about the single payer, so you know that in the US there was Obamacare was introduced. It was introduced specifically because a large proportion of the US population were excluded from private insurance, and they were not poor enough to be on, is it Medicare or Medicaid? I can never remember. One of them is for people in the lowest income. So there were basically a large number of people who were sort of the missing, I don't know, middle, whatever. So Obamacare was introduced to try and force private insurance to provide care packages that could be affordable to a range of people. But it wasn't a single payer. It was multiple insurance schemes. So they talk about the healthcare marketplace. And many people in the US are very upset because they were pushing for a single payer, because the point of a single payer is you can bargain the prices down. The word that's used is called monopsony, but it's like having a monopoly on the purchasing. So if you're the only person who can purchase something, the providers can't charge more than what you're willing to pay. Okay, so that's the opposite of a monopoly. So that's why the NHI is very important to be a single payer. If we get an NHI which allows the medical schemes to carry on in future as separate medical schemes, we've lost the power of a single payer. And that's key to insurance. If we don't have that, there's no point having an insurance. Okay, are we okay with that? Can we go on to the much easier point about the right of access to healthcare? Who had that? Okay. Right of access to healthcare?
Yeah, so the right of access to healthcare, that everyone can access healthcare, that is not determined by your income, for example. But the question that we had was around whether this right to access healthcare, or whether it's a right to access a health provider that has been accredited, and what does that mean for public healthcare institutions that are not accredited, and that may be where people live.
Yeah.
And another question is around the right to access healthcare. That's not dealing with a quality issue, and if you're going to be penalized for going elsewhere, as you said, it says in the bill.
Yeah.
So what are you actually able to access?
So those are two very good points. So if you have to accredit a facility, and that's what the bill says, you have to be accredited in order to deliver services. Can you think of any areas in South Africa which might struggle to get accredited? Sorry? Anyone? Sinisipo, are you answering?
No, we're preparing for the next point.
Okay. Anybody, so what parts of South Africa might struggle to get accredited, their facilities? Eastern Cape? Why the Eastern Cape? Rural. So in rural areas, we know that facilities are struggling, they're under-resourced, don't have enough staff. You apply the Office of Standards Compliance and they don't pass. There isn't a private sector facility nearby that could be accredited. So what are people going to do in those areas? So it could become a form of discrimination, and that's the opposite of access. And then linked to that is quality. You can't have access to care that's of poor quality. That doesn't make sense. So it has to be access to healthcare of decent quality, however you define it. Okay, social solidarity.
So social solidarity is unity that produces or is based on unities of interests, objectives, or standards. It ties in a society that bind people together as one, and that's what the NHI is supposed to provide for us, and it's supposed to engage, to get buy-in and support from different people at different levels. Of society.
So in fact, by having an NHI, we can actually build social solidarity. You need it for it to work, but it can also build social solidarity. Okay. Equity.
So we basically thought about the fact that equity is very different to equality.
Yeah.
Like you would want to assume that you're providing sort of the same healthcare to all, but there are existing factors that might not make that possible. So for instance, in the rural case, not having access to different or better healthcare facilities. So you have the choice, but you wouldn't be able to access your choice.
Yeah.
And also so I mean, there are examples in which equity sort of you have to have in order to access it. Yeah.
Okay, so you don't have to be a Marxist to believe that people who have more need should get more services. So it's according to your need. Okay. I don't know if you remember that slide of the different districts. The most expensive district was Namakwa. And why was it the most expensive district? Anyone been to Namakwa land? It's very sparse. So if you think about it per capita, you have to spend more money because you can't divide up one physiotherapist in 20 villages of 500 people each. So it becomes more costly to service rural areas, and that's appropriate because they have greater need. And so you have to spend more. Okay, healthcare is a public good. Who did that? Yep.
Healthcare is a public good.
Yeah.
It has access to affordable and cheaper quality medication. To understand the challenges of the ground levels, and all the people from the ground level must know their medicines, and they must tell him which kind of medicine are you using, which kind of treatment you are up to now.
Yeah. Okay.
So they must facilitate the people from the ground level to understand.
Okay, so that's talking about empowerment of the people who are using the service?
Yes.
Okay. All right. And it's also quite closely linked to the social solidarity question as well. Okay.
And then to add on that one, since in South Africa the majority is using public hospitals, public clinics,
yeah,
which means that no wonder that we are a developing country. because the health care is not the same as it is in public, as it is in private. Public care and private care, there is a difference while the majority is using public. So which means that if the public health care can be the same as the private health care, then the South African economy will increase, which means that the jobs, there will be more jobs created, there will be, so things will be more better if the public can be taken care of.
So it will be better because there are more jobs, but also because people will be healthier.
Yes.
Not just because of healthcare, but healthcare will contribute, and healthier people will be able to contribute more to the economy. So that's what we mean by public good. Okay. Affordability?
On affordability, we said NHI should be affordable. It should be accessible, despite your financial status. Whether you are rich, you must be. I mean, whether you are poor, you must be subsidized by the rich.
Yeah.
When you are weak, you must also be subsidized by the healthy.
Okay.
So we are saying that people don't end up have to sell their houses, their cars for operation and cancer treatment and so forth.
Okay, so that's affordable to the individual, which is sort of closely linked to financial risk protection.
Yeah. So we also say that we also ask that are there going to be strict regulations to regulate the private sector, the charges and all that, so that it becomes affordable. We don't get the funds do not get milked out by the service provider. Thanks.
Okay, so under an NHI though, there would be no costs to the person. Okay, so the regulations currently in place are trying to prevent medical schemes charging too much to medical scheme members, but under an NHI nobody would pay. So affordability to the individual is one thing, but what about affordability to the country? Okay, so the principle also talks about we need to have an NHI that we as a country can afford, but how you decide that is another question, because you could spend more per capita on health than you might spend on defense. Or you might have to decide between housing and health, or education and health. So those are not so easy questions. Did anyone do 13, efficiency? Did we stop there? Yeah, you did efficiency, yeah?
Yes, number 13 point, efficiency. Okay, because you also show us the slide that was telling us about the expenditure of and the support of our government, that they are spending 43% to the rich people or the private sectors and 44% to the poorest. And you also show us the history of NHI negotiations, of which they take long and long to come back to us. I think the strategy that we can use, and we must not stop in using, it's education. Strengthening the basic education of the health. One, we know that most accidents are made it's because of the people that using drugs and substance abuse, and of which they make people to be more involved in accident, end up being criticals. And then that education of drugs and substance abuse need to be emphasized. And then we know that, again, you show us the slide of the children that are affected by the diarrhea. We have the basics health of the mixture that we need to educate in our community and make sure that we reach the poorest and the grassroots people. And then again, our health care services or facilities in our community have been overcrowded by people sometimes who don't need to be there. I'll make example. Some of the people, they've got rash and not they need calamine or any medical issues, but to take care of the environment, the water that are next to their houses, And then therefore we need to do the basics education so that they can understand themselves, and knowing that we really need to be educated in terms of the health. And lastly, we know that our hands can make a lot of illnesses. We still go to the preschools. We need to go to the mothers that carrying young children to make sure they wash their hands before they touch anything to put in the mouth. And that we really need to understand our target groups on that. Parents and the young children, so that we can get a healthy environment and a strong environment in the terms of health. I think education can manage to close the gap between the poor and the riches. Thank you.
Okay, so you've raised the point about prevention is often more efficient than treatment. Okay, and the NHI should prioritize prevention if it's going to be efficient, and there are other problems in the health system that are quite inefficient that must be corrected. Okay. Did we go on at all to effectiveness? No, appropriateness. So effectiveness is basically the NHI should fund services that we know work. Okay, there are a lot of services that are delivered that don't make any difference, and we shouldn't be putting money into things that don't work. And appropriateness is also about how communities feel that a service is delivered in a way, or it's choosing the priorities of people who, of what people identify. So we've rushed through this. We've spent a lot of time on this because they are the principles of the NHI and around universal access. We're probably going to have to just touch on a few more slides before breaking. Is lunch ready? Yeah. Okay. So the NHI is going to be a package of personal services. That's what they say, and it's going to be rationed. There is supposed to be disincentives to encourage people to use facilities close to home. There's going to be an NHI card. You're going to go via your primary care facility where there'll be a multidisciplinary team. There might be contracted private providers. You're going to be referred upwards if you need to be. But there's a benefits advisory committee that's going to decide what the NHI will pay for. So in other words, some things the NHI will not pay for. So that is a very key committee. But if you read the bill, what the NHI is focusing on are the personal services you get if you go to a physiotherapist, or you have had a stroke and you need rehabilitation, or you've got high blood pressure. It's not focusing on prevention upstream. Okay, it says it is, but it's not really presenting any of that. So the minister's views, when we told him there was a crisis in the public health sector, his response is, well, there is no crisis, or if there's a crisis, it's a fault of the private sector because they use so much money, and we want that money to try and fix the public sector. Okay, his comments on equity, the world will never become a fair place by itself. I agree. Fairness, especially in matters of health, comes only when equity is an explicit policy objective. So the minister and the department do make those statements. Human resources for health. There are people who wrongly believe we can do the NHI without addressing our human resource challenges. Nowhere in the world did countries introduce NHI where everything was hunky-dory. They introduced it when they were not well off. It was a political decision. Okay, and the history of the NHS in England is like that. The medical fraternity opposed the NHS very strongly because they thought they'd lose status and power. But there were strategies to overcome them. And he talks about primary health care as a heartbeat, says the minister. I wish to take this opportunity to emphasize again that the NHI will be based on a preventive and not a curative health system. 2013. So the key challenges for the NHI is, as you have said, we have to build the public sector. So the purchaser-provider split, the idea that there will be a fund that will purchase services from providers, is exactly what some of you have said. Is it going to purchase from the public sector, or is it going to go to the private sector and strengthen the private sector? We have to build the public sector. There was the first survey of the Office of Health Standards Compliance found that less than 1% of public sector facilities met their standards. It's gone up a bit, but it's still very, very poor. Equity is said to be non-negotiable, but we know that rural facilities and public facilities will struggle to get accreditation. And there's no plan from the minister or the department to say we're going to fix the public sector. For a quality NHI, we need sufficient numbers of appropriately trained and supported health workers, but the human resources plan for this country is very weak. There's no direct mention of community health workers, although very recently the department has adopted a policy on community health workers. And if primary healthcare is the heartbeat of the NHI, that pulse is very, very weak. So remember, if you look at how we determine health, there are a lot of things which shape health, which the NHI is not going to address those problems. It's also silent on participation. Civil society was initially excluded from all the implementation structures from the NHI. After we complained that the NHI had been captured, there was suddenly a revision of these structures, and now civil society was included, one on each committee, very token, but there's no real recognition of participation. Migrants are essentially excluded, depending on their status. The private sector is in these committees that meet about the NHI. And for instance, there was a plan to consolidate GEMS, government employee medical schemes, as the main vehicle for NHI, and that will entrench the inequalities because it will create a fund for public servants and a fund for people in the formal sector, employees, and then the fund for the small businesses, and then the fund for the rest. And once you create those funds, international experience shows that you can't undo them. So what can we learn? As you've said, social solidarity is essential, but it won't happen by itself. We know that health is more than healthcare, and this NHI is not really addressing health in the broad sense. Participation is the issue. There are many vested interests around the NHI. The people who are most vulnerable, they're the people who need to challenge the NHI. So we need to strengthen the agency of communities. And if we have a single payer and we have common benefits, then perhaps it's all possible. So what the PHM is campaigning for is a people's NHI, where participation is central. A one-payer system finances healthcare or in health. It's pro-public. So let's mobilize for an NHI for everyone based on social solidarity. And that's our view of a people's NHI. And we have been working with Section 27, TAC, RHAP, and others to develop a campaign. And this is part of what we're trying to do here, is to train trainers so that you will go back to your organizations and your areas and take this forward across all the provinces. So some people are here from other provinces, in fact from Mozambique, but this is part of our agenda actually to try and seed this further, and we might be holding this in other provinces. So I think I'm done, and that is lunch.